Yeah, thank you, sir, for the kind introduction. At the outset, I would like to thank the organizing committee for this opportunity. As sir said, gender dysphoria is a very difficult topic. So, in fact, it was when I'm trying to build an update, I had a doubt like how many of the audience would be very well aware of gender dysphoria. So, I have tried to build some updates on the base of some already known facts. So, please bear me if I'm repeating some of the very well known things for the seniors here. So there's some issue with the slide change. So the first update about the gender dysphoria is actually the revision of nomenclature. In fact, ICD-10 used the word gender identity disorder to refer to gender dysphoria. In 2013, when DSM-5 came, they brought in the term that gender dysphoria and gave criteria to define it. But even gender dysphoria was classified under the mental health chapter, right? So, but like there was a lot of requests going on from the group that we are not like disease suffering persons, right? So now WHO take an initiative and it was reclassified in the ICD-11, that is International Classification of Diseases 11, as gender incongruence instead of gender identity disorder. Probably it's even a milder terminology than gender dysphoria, because gender dysphoria need not be present in all the patients who suffer from gender incongruence. Another important observation here was that they moved that gender dysphoria or gender identity disorder from mental health to sexual health chapter, which clearly depathologizes the gender incongruence, saying that it's not a disease, probably it's a diversity. So of course there are two classifications there, one limiting to adolescents and adults, and another one for children. So gender incongruence is defined as the marked and persistent incongruence between the individual's experienced gender and the assigned sex. And in fact, it also mandates that it should last for at least several months in adolescents, whereas it should last at least for 2 years in children before you label them as gender incongruence. Right. So let us look at the trends of gender dysphoria in the world. So most of the data for gender dysphoria is actually coming from Netherlands, that's Amsterdam. So if you look at the data, there is a clear increase in the number of cases referred for gender dysphoria after 2012, right? And another important thing, what you can see here is, there is an increase, a disproportionate increase in the number of youths who are referred for change from female to male. Probably in India, it's actually the ulta, right? So we are seeing more number of cases who want to get converted from male to female. But the current trend in Europe is actually like more of the youths are referred to get converted from female to male. It's also the case even in a study from UK, right? You can see that the number of cases have increased significantly, and there is also a trend for higher proportion of youths coming for female to male conversion. Right. But the next question arose is this increase in the number is just a representation of more references or of like probably less dysphoric or maybe gender dysphoria mimics? Or is it really that so many cases of gender dysphoria are existing and they're truly referred? So that was answered by this latest study, which said that the percentage of adolescents diagnosed with gender dysphoria, whether it was a decade ago or now, they're exactly same, right? So to take an information from another point, even the percentage of gender dysphoria diagnosed adolescents who received medical treatment, this hormonal therapy, they're also exactly same, whether it may be a decade ago or now. So what it says, it's not the percentage of or proportion of patients who have changed. It's actually the number has actually been truly increased, and probably they're seeking more of medical attention only because now the gender dysphoria clinics are more amenable to contact. So I expect probably these are definitely the same changes which we can expect a decade or two later in India as well. Right. But Even then, despite saying this about adolescents, even today, even in Europe, most of the transgender care seeking patients are actually adults, right? But what you can appreciate now is that since maybe around 2005, there is a good number of children and adolescents, both among trans women and trans men, which are seeking transgender care. That's probably the need why we as pediatric endocrinologists should also be aware more about gender dysphoria management. Right. So at what is the common age which they will usually reach at? It's actually most commonly between 14 to 17 years. Most of them had like post-pubertal development at the time they presented to the endocrine departments. And also there is a good amount of patients who are getting referred between 8 to 12 years. And more interestingly, nearly half of them have also been referred for endocrine treatment. But very important thing is that if you look at the overall number of cases who present with gender dysphoria at any gender dysphoria clinic, only few of them, maybe a very small proportion of them really had gender dysphoria, right? It may vary from 2% to 39%. So, but very important message from this is that don't label all children, especially less than 12 years, who present with complaints of gender dysphoria as gender dysphoric. We have to give sufficient time for them to identify themselves, at least around the pivotal time, whether really they're gender dysphoric or not. In fact, most of these children who present as gender dysphoric during childhood identify themselves as gay during the later part, maybe during adolescence or adulthood, but not as truly gender dysphoric. That caution has to be executed. Right. So once we know the trends, it's time to understand our management in our clinics. Probably it has a lot of implications, especially the legal implications, right? So whenever a child or an adolescent reaches to us for endocrine treatment for gender dysphoria, the first thing we need to ensure that they have been confirmed to have gender dysphoria by at least one qualified mental health professional using DSM-5 criteria. So unless you have not documented it, better you refer the patient back to your psychiatric colleague and get the diagnosis confirmed about it. Right? So what are the treatment options available for gender dysphoria? One is the stage 1. It is divided into stage 1, stage 2 and stage 3. The stage 1 is the pubertal suppression. Stage 2 is the gender affirming hormone therapy, and stage 3 is gender affirming surgery. When I say gender affirming hormone therapy, it means institution of cross-sex hormone therapy. So that is gender affirming hormone therapy, right? But we are always been confused about the guidelines and when we think about the legal issues. But as of now, there are 3 guidelines which are available. The one by the WPATH, that is World's Professional Association for Transgender Health, published in 2012. The other 2 recent guidelines, both are in 2017, one by Endocrine Society of America, another one by a local group from Kolkata, sponsored by SAFO. It's an organization of LGBT. If you look at these guidelines, right, the PATH and WPATH and Endocrine Society say referral by one mental health professional is more than enough. But though we cannot nationalize these guidelines, the only available Indian context guideline says at least 2 mental health professionals should refer to start any hormonal treatment. Then look at the other guidelines, like these patients should have long-lasting and intense pattern of gender nonconformity or gender dysphoria, and gender dysphoria should have emerged or worsened with onset of puberty to consider pubertal suppression. Any coexisting psychological or medical or social problems that could interfere with treatment have been addressed, and the adolescent should have given informed consent, and particularly when the adolescent has not reached the age. In fact, in India it's 18, so to give legal consent. So in that case, probably you have to obtain the consent of parents, preferably both the parents, and then start on treatment. Endocrine Society also mentions all the 4 guidelines given by WPATH, but it also gives a bigger role for pediatric endocrinologists to or another clinician who is experienced in pubertal assessment to agree with the indication for GnRH agonist treatment, confirm that the patient has already entered a Turner stage of 2 or more, and also confirms that there is no contraindication to GnRH agonist therapy, right? And it also emphasizes and makes its mandate to explain the adolescent on the effects as well as side effects of the treatment you are giving, and also the options to preserve fertility before even initiating pubertal suppression. But if you look at the guidelines of GAC, that's like Kolkata guidelines, there are no separate guidelines for pubertal suppression and hormonal treatment. I mean, for the stage 1 and stage 2, the guidelines remain same because they have gone very conservative, which makes our situation to treat adolescents very difficult, right? Even if you look at the guidelines for gender-affirming hormone therapy, they are almost the same, right? But usually here, even WBAT says it's better to start once a child has reached a legal age, right? Which is 18 years even in India. And whereas the Endocrine Society adds up here, again, another role for endocrinologist is that we have to confirm here that the indication for sex hormone treatment is there, and there is no contraindication of sex hormone treatment, right? So I think we need to be aware of these guidelines. I'm not going to go into the details because that will take much of time. And once we decide for pubertal suppression therapy, you know the treatment of options. It is GnRH analog therapy, right, which could be Liprolide, 22.5 mg once in 3 months, or even we have like little more increased interval based regimens such as Triptorelin, which could be given even once in 5 to 6 months at the dose of 22.5. So if you look at the pubertal induction regimens, they are different for somebody whom you have arrested the puberty at by around stage 2 or stage 3, and for somebody who have completed their pubertal development. So those who come with pubertal, whom you arrested puberty at a very early stage, you go a little slower and reach the adult dose by 2 years. For somebody who already had a puberty completion, you can advance the cross-sex hormone therapy faster to reach the adult dose by 1 year. So if you look at this latest study where the systematic review was done on hormonal treatment in young people with gender dysphoria, they are very effective in achieving the physical effects. But are they effective in achieving the benefits and psychological outcomes? In fact, GnRH analog therapy improved psychological functioning, but not the gender dysphoria itself, whereas psychological benefits of gender-affirming hormonal therapy, the data is not very clear enough. Of course, we need to monitor for complications is the most important thing. And in fact, in the latest study, if you look at, there is liver enzyme elevations were seen in around 2.5% of trans men. That means those who receive testosterone, and 4.5% in the trans women. But in both of them, they were transient in most of the cases. Acne is one of the most common manifestations seen in nearly around 45%. Erythrocytosis is seen in around 6% of trans men, whereas venous thromboembolism, which was one of the dreaded complications, is seen in up to 2% of trans women. Right? So another important aspect or side effect is actually the risk of cancer. So the invasive breast risk cancer as well as the non-invasive breast cancer risk was significantly higher in trans women. Even it was also higher in trans men, surprisingly, who received testosterone, right? And another interesting thing is there is also like increased risk of the benign brain tumors, right? Such as like meningioma as well as prolactinoma among trans women. And very surprising thing is there is also a tendency for increased occurrence of somatotropinomas, that is GH secreting tumors among trans men. Of course, we need to follow them regularly, not only for the effects of the hormone therapy, but also for the side effects. I think these are all available in your standard Endocrine Society guidelines. Another important point is give very realistic hopes for these disparate transgender patients who are expecting or who just want to change in a fraction of a second to the opposite sex, right? Because whenever you start hormone therapy, they will take their own time of years together to induce the changes. One update I wanted to give from here is that in a recent study, there was the median time to reach amenorrhea was Testosterone therapy alone was around 3 months. And in fact, those who achieved higher levels of hemoglobin at 3 to 2 months after follow-up are the one who really achieved a quick cessation of amenorrhea among female to male conversion transgenders. I think I'll stop here.
Yeah, I think it was a wonderful talk. It was such a complicated topic and he's covered a lot in 15 minutes. We need to give him...